In Chapter 14, we will be going over the foot and toes. Moving forward with most of our lectures, we are going to be touching on different parts of the body, and we will follow a similar format for each of those lectures. So first we'll start off with anatomy. The first thing we're going to talk about with the anatomy of the foot is the bones and ligaments. So in the foot, we have approximately 26 bones. We have the phalanges or toe bones here, the metatarsals or midfoot bones here. The tarsals or ankle bones are all here. So the ankle bones come a little bit forward from where you would look straight down from your shin bone. So the shin bone is going to stop about here, and then you're going to have your ankle bones or your tarsals in front of that. For the most part, I'm not going to ask you to memorize the names of the different bones in the tarsals. However, two that are important are the talus and the calcaneus. The calcaneus is down here. This is your heel bone. So if we looked at it from underneath, that would be your heel bone. And then the talus is where the tibia and fibula sit on top of. Now, when we talk about ligaments for the foot, we have joint capsules for interphalangeal joints. So this is our interphalangeal joint, so between one phalange and another. So we have one interphalangeal joint in the big toe, two in the other toes, so right here. And even the baby has two right there. Okay, so those are so we have the joint capsules of those joints. We also have the tarsal ligaments, so ligaments between each of the tarsal bones. So the tarsal ligaments would be, say, for instance, between these cuneiforms here, and they'd probably span the length and the width of that bone between each of the other bones. So each of these spaces right here between the bones, there's going to be ligaments in there holding those bones together. We also have intermetatarsal ligaments. So in between the metatarsals, there are ligaments as well. So there'll be a ligament that's running here, a ligament that's running here, and then just some ligamentous type tissue running here between the bones to hold everything together and add stability to the midfoot there. And then we also have our plantar fascia, which is on the underside of the foot. And I believe we have a better picture of that on a later slide. But it basically helps to support the arch. As far as arches in the foot, we actually have more than one. So we have our medial longitudinal arch. So that's the arch that most people think about when we think about the arch. It's the arch on the big toe side of the foot that runs from the heel to the ball of the foot. That's our medial longitudinal arch. But this is also on the underside of the foot. We also have a transverse or metatarsal arch here under the ball of the foot, basically. And then we also have a lateral longitudinal arch on the pinky toe side of the foot. Those two aren't always readily noticeable on people who have flat feet, but you'll see them more clearly on people who have angular feet. But any of those arches could be injured or damaged or start to fall and cause some discomfort. Next, for anatomy, we're going to talk about the muscles and tendons of the foot. The flexor tendons of the foot actually start as muscles in the lower leg in the posterior medial side of the lower leg. They're going to run behind the medial malleolus and then come under the foot to their respective places. So these tendons are known as the Tom, Dick, and Harry tendons. So the first tendon that we will talk about is our Tom, which stands for tibialis posterior. So that will come behind the medial malleolus, go across the bottom of the foot, and when it shortens, it will hold the arch up by pulling in that direction. So that is the tibialis posterior, holds the arch up. Next, we have the flexor digitorum longus. So that also runs behind the medial malleolus. And now we're going to go to digits 2 through 5. This is the dick muscle in the Tom, Dick, and Harry. So digits stand for little toes. So flexor digitorum goes to the little toes. So toes 2 through 5. Next, we have our Hairy tendon, which it stands for the flexor hallucis longus. Another term for the big toe or great toe is hallux. So that is going to come from behind the medial malleolus to the great toe or big toe and flex that toe. So those are our flexors. Tom, Dick, and Harry. Tibialis posterior, flexor digitorum longus, and flexor hallucis longus. Our extensors for the foot come from the anterior medial side of the lower leg down to the toes and to the foot. And I'm not going to ask you to know the names of those separately. We also have muscles that originate in the foot and stay in the foot, and those are known as interosseous muscles. So those are primarily going to be between the metatarsals down here, helping to support those joints and to support the arches of the foot in those regions. Next, we want to talk about prevention of foot injuries. First and foremost, we want to make sure that an individual is wearing proper footwear. So if somebody needs a stability shoe, they should be in a stability shoe. If they have a flexible flat foot and they want to try to strengthen their foot by wearing barefoot shoes, that's okay, as long as they use them very sparingly and break them in extremely slowly. If somebody has a very flexible foot and they're wearing barefoot shoes too much, they're going to give themselves an injury. I once saw a gentleman who was between 250 and 300 pounds running in a marathon with barefoot shoes, and I don't feel that that was his best choice. He looked like he was in an awful lot of pain by the time I saw him. So barefoot shoes should be used primarily as training shoes and not as competition shoes, and also they should be broken in very slowly. We want to also make sure we're wearing well-fitting shoes and socks to prevent skin and nail injuries, in addition to other types of injuries that could happen to the foot if the shoes were too tight or too loose. We also want to make sure that we're taking into consideration adaptation to contact surfaces. So it is helpful to know that irregular surfaces can strengthen the foot and leg. However, if there's an individual who already has an overuse injury and they're training on irregular surfaces a lot, they could start to cause some more irritation with that overuse injury. Another thing to consider is that hard surfaces can overstress bones and ligaments and muscles, while soft surfaces can cause early fatigue. So it may be better to alternate between those two types of surfaces more often. So instead of only running on concrete, it would be nice to give your feet and legs a rest by also running on shorter grass or a soft track, say for instance, but switching up the training surfaces so there's not a lot of stress either direction. Good hygiene is also really important to help prevent skin infections like fungal infections and things like that. Also, if an individual has a lot of issues with their arches, an arch support such as an orthotic could be helpful. Orthotics they can be custom or semi-custom depending on what the individual's needs are. But usually we don't put somebody into orthotics if they haven't had repetitive injuries, unless they have very poor mechanics. So if we look at somebody's foot and it's just falling all over the place, it's super flexible, they're having a hard time supporting their foot or their leg, then we might consider putting them in orthotics if they don't have a complaint of repetitive injuries, but most of the time we don't go straight to orthotics, we go to foot strengthening first. If somebody has poor mechanics and repetitive injuries, then we'll definitely look more towards orthotics. So custom orthotics can cost $400 or more. So usually what I try first with somebody is to see if they can try a semi-custom orthotic like the brand Superfeet, and they pick out an orthotic that seems to describe their arch most consistently, and then they wear that in their shoe for a little while to see if it helps. If it helps all the way, great, that's what they'll wear. If it doesn't help quite enough, then they might be interested in looking into the custom orthotic. As far as assessment of foot injuries, we will follow our HOPS protocol for assessment. And I'd like you to remember that any information here is for informational purposes and to help with triaging an injury. You will not be able to accurately diagnose an injury necessarily following this lecture or this series of lectures. So just keep that in mind. This is for informational purposes to try to get your brain to start thinking as a clinician or as somebody who could help somebody with an injury. So first in that HOPS protocol, we're going to start with history. So we're going to start asking the person questions. So we're going to ask them about their mechanism of injury. So how did it happen? Did they twist their foot? Did they overstrain their foot? Did they get stepped on? What kinds of sensations did they have? Did they have pain or crepitus like crunching? Or do they feel muscle weakness? Especially for the foot and lower leg, we're going to be asking about their training. So we're going to ask about what kind of surface do you train on? Do you run on the road? Do you run on grass? If they are a distance runner, do you run on the sidewalk or do you try to run on the asphalt instead? We'll ask them about any changes in training or footwear. If somebody has increased their training a lot recently, they could be at risk for many different types of overuse injuries. Generally speaking, we don't want to increase training more than 10% a week. And again, changes in footwear. So have they changed the type of shoe they wear? Have they been wearing that same shoe for a long time? That's another thing. If a distance runner has been wearing their shoes for more than a couple months, they probably need to replace them because the shoe itself is starting to break down. We would also be interested in any type of previous lower extremity injuries they have. Even if it's not the exact same injury, it could be helpful information. Next in the HOPS protocol, we're going to do observation. So we're going to check for any swelling, either edema or effusion. So edema is swelling outside the joint. Effusion is swelling inside a joint. We're going to look for any bruising, which is also known as ecchymosis, or redness, which is known as erythema. We're also going to look at the person's foot structure. So do they have a high arch, which is technically known as pes cavus? So pes refers to the foot, and high arch you can kind of think of, they have a little cave that they built with their foot. So pes cavus would be like a little cave, so they have a high arch. Low arch would be pes planus. So low arch would be flat or maybe even really low, kind of touching the earth too much. But I kind of think of pes planus as that low arch is planted on the ground. So planus, planted on the ground, low arch. Next, with our HOPS protocol, we will be doing palpation. So we'll be touching the foot, looking for pain and any abnormalities. So we're going to try to palpate the bones and joints, and then the tendons and ligaments. If you're trained how to take a pulse in the foot, then you could do that. We do that at the dorsum of the foot. We call it the dorsal pedal pulse. Pes, pedal, those refer to foot. Next, we would do some special tests, and there are others besides these, but two that are very common would be compression tests, so squeezing the sides of the foot together, checking for fracture, and then we could also do a tap test. So if it was an injury to the toes, we would tap on the end of the toes, say for instance, to see if that shot pain down through the area that was injured. We could also try tapping on the toes for the metatarsals too, to see if that shot pain through the metatarsal area. Jumping into some injuries. We have two different injuries on this slide, partially because I like to compare and contrast injuries that are similar that could get confused with each other. So occasionally I'll have two injuries on a slide instead of just one, and this is one of those slides. So our first injury is a heel bruise. So that happens when somebody steps down on their heel very hard. It can also happen if there's maybe the padding in somebody's cleat has worn down a bit in the heel area, and then they step down hard in the cleat and a cleat pokes them right in the middle of the heel, kind of in this particular region. That can cause some bruising. So signs of that would be that we'd have a mechanism of a hard force to the heel, so they'd land on it really hard. Their signs would be pain in the middle of the heel on the plantar surface. And the treatment for that would be rest for 48 hours, so no running, try to avoid walking on it. A donut pad, which is basically a pad that we would cut out of a piece of foam where there would be a hole in the middle, and then the pad would run around like this. So this would all be padded in, all the donut area, and then there would be a space in the middle. We'd put the bruised part right in the middle of that hole to try to keep the bruise from getting irritated when the person walked on it. Then we could also do some ice massage. So that would be the ice massage with the Dixie cup, the frozen Dixie cup. So that's a heel bruise. Plantar fasciitis is pretty different. The mechanism here would be overuse, so quote unquote overuse. This would happen over time, not from one particular hard step. And this can be also caused by mechanical problems in the foot. So we might see somebody who has a tight arch or calf, if they have issues with their arch in general, like maybe a very low or very high arch. They could have what we call a leg length discrepancy, so one leg could appear to be longer than the other, which usually happens at the pelvis, with the rotation at the pelvis, but it can affect the feet. They could have poor support in a shoe that they're not strong enough to deal with. They could actually have a running stride that's too long, or they could be running on a soft surface a lot. A very common mistake that people who run will make is that their running stride is too long. So that's one of the first things that we can look at too if we're trying to help somebody fix some issues that they're having either with their arches or their shins or their knees as well. Signs for plantar fasciitis would be pain toward the medial side of the heel. So it's not right in the middle. It's actually more towards the big toe side, right in there. And it's usually it's worse on the first couple of steps out of bed in the morning. So sometimes the pain will spread into the arch, but it does not go all the way down to the toes. And it happens when the foot has been in a relaxed position for a long period of time, and then they go to step down on it and they overstretch that plantar fascia. So it's pulling on the part that hurts because it has been in a shortened position all night. So that the pain on the first couple steps out of bed is kind of our biggest red flag that this person could have plantar fasciitis. Our treatment for this would be a calf and a plantar fascia stretch. So with the plantar fascia stretch, usually we just kind of pull the toes back towards the shin with our hands, and then calf stretch would just be a normal calf stretch. We want to fix their mechanics if there's any problems with that. So again, we'll ask them to try to shorten their running stride a little bit, possibly. They could be put in a night splint. So there are a couple different kinds of night splints, but generally speaking, the night splint will just not allow the foot to be in a pointed position at night. It will try to keep the foot in a more 90-degree angle with the calf. Sometimes they use like a little strap that goes up to a sock, like a knee-high sock, or sometimes the night splints will almost look like a walking boot that goes on the back of the ankle that holds and you strap the foot in to hold it into a more dorsiflex position while sleeping. What else? And then the person could also use a heel cup, which is like just a special little insert that just goes over the heel in the shoe. An arch support often helps, especially if the person has a very low or a very high arch. And then ice massage over that area can still help. Another type of injury with the foot is a metatarsal fracture. So there are several different ways that we can fracture the metatarsals. They could get stepped on, say for instance in a soccer, football, or rugby game, that's common. The person could kick an object and the force could be relayed up to the mid part of the foot. Or the person could twist their foot somehow. Like maybe somebody stepped on their foot and then they went to a twist, or they could have rolled their foot over the top but not quite rolled their ankle. If somebody has like a cut and twist type of mechanism that causes this, then you can get a little fracture here right at the base of the fifth metatarsal, and that actually has a special name. It's known as a Jones fracture. Those are acute ways of having a fracture. You can also get an overuse stress fracture, which is most commonly occurs at the second metatarsal, and that's usually due to what we call a Morton's toe. So if you look at your toes and your big toe is shorter than your second toe, then you would be at a slightly higher risk for getting a stress fracture in that second metatarsal. The interesting thing is that it's not, if you do have what we call Morton's toe, or that shorter first toe, it's not actually the toe that's shorter, it's the metatarsal that's shorter. So what happens then, instead of the first metatarsal taking up more of the stress from walking or running, the second metatarsal has to take up more of that stress, and that joint isn't, or that bone isn't as equipped to do so. That joint isn't quite as strong. So our signs of a metatarsal fracture, it can be really hard to differentiate between a sprain and a fracture in the metatarsal area because the bones are so small, and the ligaments kind of run the length of the bony area as well, holding the bones together long ways. So sometimes those fracture tests can be helpful, so the squeezing of the midfoot or the tapping on the toes. The person should be tender to palpation more directly over the bone versus in between the bones, and they may have a palpable deformity. So you may feel a little ridge or like a bony projection in a spot that feels like it should be smooth. Treatment for metatarsal fracture would be x-ray to confirm it. If it's an acute fracture, so we need an x-ray to know for sure, or a bone scan for a stress fracture. Because again, usually with stress fractures, those aren't going to show up on an x-ray until they're starting to heal. If somebody does have a confirmed fracture, then they could be put in a walking boot or a walking shoe, which are very attractive orthotic shoes, but they do help hold the foot still. Or maybe even be casted for 3 to 6 weeks. If it is a Jones fracture, over on the side of the foot right here, that is actually caused by the tendon pulling off a little piece of the bone. So usually they're going to be casted on a walking boot for 6 to 8 weeks because the doctor really doesn't want that tendon pulling that piece of bone any more than it needs to be. So that needs a little extra healing time. Displaced fractures of the metatarsals could technically require surgery, but I haven't seen too many of those in my time. Another type of injury we could get to the foot would be a longitudinal arch strain. A mechanism for this would be unusual stresses that flatten the arch in the mid-support phase. So when the person is standing basically with all their weight on their foot as they're walking, that's when they're going to have a lot of stress on their arch. This particular individual has such a low arch, I would almost call it a subterranean arch. It's very, very low. So subterranean would be below the earth, right? So that arch is very low. This person probably doesn't have a lot of stability in their midfoot here, and then their tibialis posterior running through here is not holding up the arch super well either. So these longitudinal arch strains can be acute or chronic. So it could be from a bad fall, possibly from a jump or like landing from a jump, or it can be chronic. It can happen over time. but this is often in people who already have pes planus or a flexible flat foot. If somebody has a rigid flat foot that just looks the same whether they're standing or have their foot up in the air, then that doesn't necessarily make them at a higher risk for this. Some signs would be extreme pain with weight bearing, and pain and or swelling beneath the medial malleolus and the tibialis posterior tendon area, so right through here would be where we would see most of that swelling. Our treatment would be price. So weight bear is tolerated, but if it was hurting them a lot, then we would have them on crutches or partial weight bearing. Putting an arch support in their shoe might also help, or taping their arch might be more comfortable. And we could do some strengthening. So ways that we can strengthen, really good ways we can strengthen the midfoot are object pickup. So that would be like picking up marbles or tape roll or empty tape rolls or any army men, any small object that is unlikely to poke their toes. We would have them trying to pick up an object with their toes, or towel scrunches. I actually really like towel scrunches. What I have the person do is I have them take a hand towel and lay it out on the floor on a linoleum or wood surface preferably. And then they take their foot, so big toe, little toes, and then they try to crunch the towel towards their heel. So they slowly get the muscles more active in the midfoot by crunching that towel towards their heel. I only drew 4 toes. Sorry, four-toed person. So both of those exercises will help to strengthen the midfoot and help to give the person more stability in that midfoot. So injuries to the toes are usually relatively minor but often painful. Our mechanism for injuries to the toe most often are kicking an object or what is known as stubbing the toe. This can cause a fracture, a sprain, or a dislocation. Toe dislocations are relatively rare, but I did have an athlete who dislocated this joint on his big toe, which was a little odd. He just landed funny from a jump, and he forced the joint out of position. And that was actually not necessarily that big of a deal. He was only out of play for about a week. It would have been a much bigger deal if he had dislocated this joint instead. So the other thing that can happen is sometimes people can drop a heavy object on their foot, and that would also damage the toes. Some signs would be swelling or edema and discoloration or ecchymosis. So the individual in this top picture has both. That's a really swollen big toe, and that's a lot of bruising. So that particular individual, I would say, either has a very, very, very nice sprain or they likely have fractured their toe. Our treatment would be price. Most often, for the protection part of that, we're just going to do a little buddy tape to the next door toe. It doesn't work as well to do buddy tapes with the big toe to the second toe, so that person may want to wear one of those orthotic shoes that comes down and doesn't allow the toes to flex when they're walking. They might be more comfortable in that type of support. The person should do 3 to 4 weeks of inactivity, so they shouldn't be running on their fractured toe. And they must see a doctor if the fracture is suspected to involve a joint or if it's the proximal phalanx. So that's the bone closest to the foot. So if it's this toe or this part of the toe, then they should go to the doctor for that because it may require casting. A special type of toe injury is called turf toe. So this is a great toe sprain. So the sprain occurs at this joint right here, at the metatarsal phalangeal joint. And it happens when the toe is forced into dorsiflexion. So it's forced up this way. And it's common if the sole of the shoe is overly flexible, but it's especially common in football linemen. So that's why it's called turf toe, because the lineman would have one foot back, and then they'd have their weight plus the weight of another person that they're pushing on back on that toe. So the toe will get forced into dorsiflexion with a lot of weight on it. Our treatment for that is price, and we have a special tape job that we could do for it, or there's a stiff insole that we could put in the shoe to help keep that from happening as well. A couple of other injuries that can happen to the foot are bunions and neuromas. So these are both caused by a similar mechanism. So that's why they're on the same slide together. And this is basically most often from people wearing poorly fitted shoes. So bunion is also known as hallux valgus. So remember, hallux refers to the big toe or the great toe, and the great toe is going into a valgus position, so kind of a knock-kneed toe position. And the mechanism is poorly fitted shoes, so tight toe box or pointed high heels would definitely help to drive that, that positioning of the toe. If somebody has low arches, then they kind of tend to roll over their big toe as they walk and can force it into that position as well. Our signs for this would be tenderness, especially over this metatarsal phalangeal joint, and a bony enlargement over the head of the first metatarsal right in that region that causes the great toe to shift inwards into a medial position. So there's a bony enlargement on the head of the first metatarsal, but the damage is primarily to that first metatarsal phalangeal joint. Our treatment would be proper shoe selection, so making sure we're wearing a shoe with a larger toe box, and avoiding heels, especially pointed high heels. We might have the person try orthotics to help if they had pes planus especially. We can try splinting or taping. If none of those things work, then the person would probably have to have surgery if it progressed. Usually surgery isn't done until people are in middle to older age, but I have known some people who've had bad enough pes planus that they could have benefited even at a younger age. But basically what happens, a common surgery that I've seen is that the doctor will go in and just cut this bone and then reposition it and then kind of straighten things out through there. And I don't remember exactly how long the person's non-weight bearing for, but it's a decent amount of time. Another injury you can get from wearing shoes with too tight of a toe box is called Morton's neuroma. What happens is that the nerve that runs between the third and fourth toes can get pinched, and by that shoebox being too tight or kind of rubbing on those two bones together right there, and then the person will get severe and intermittent nerve pain and numbness in the third web space, so kind of right in here where those two toes come together. Our treatment for that would be proper shoe selection, so making sure that they're not wearing shoes that are too tight, so avoiding heels that have a pointy toe, and also wearing running shoes that have a big enough toe box. And possibly orthotics. Sometimes the orthotics will have a metatarsal arch pad possibly, or sometimes they'll have a little cutout so that there's not as much pressure on that spot. But by supporting the metatarsal arch, it kind of splays the toes out, so the toes come apart a bit, and it will take some of the pressure off of that nerve in that area as well. And lastly, we'll discuss injuries to the skin and nails. A common injury with active people or athletes is blisters. Blisters occur from a shearing force or rubbing force on the skin from socks or shoes. So we can help prevent this by wearing properly fitting socks and maybe using a skin lubricant possibly. Some people really swear by wearing 2 pairs of socks as well, so that the socks rub on each other instead of the skin. This is a pretty nice blister this person has going on here. I have a feeling that could be from a tape job or from a really poorly fitting pair of shoes, but that is a very large blister. If if somebody has a blister of this size, probably putting a Band-Aid on it is not going to make much of a difference. They're still going to have a lot of pain. So if somebody has a smaller blister, we could go ahead and just put a Band-Aid on it. This person might want a donut pad, so remembering the pad that has the hole in the middle to keep the pressure off. That's a terrible donut. To keep the pressure off of the blister. So that hole in the donut would go directly over the blister. Sometimes there's a special dressing called second skin that could be very helpful. It's kind of like a slimy, slippery dressing that you can put over the raw skin that helps it to feel more comfortable, and it helps to reduce the friction in that area. If we have a blister that's filled with fluid, we shouldn't lance it or pop it unless we are unable to comfortably pad it, because there's a high risk of infection, especially on the feet. So we really want to try to avoid popping blisters if we can help it. Next, we'll talk about ingrown toenails. So an ingrown toenail is when the edge of the nail, so right through here, grows into the skin next to the nail. And it's common on with the great toe, although it can happen with other toes as well. And that little area will get really red, swollen, inflamed, and infected. It's pretty gross looking. Sometimes they'll even weep pus. For ingrown toenails, shoe fit is also important for this. We don't want the toes to be banging into the front of the shoe. We also don't want the toe box to be too tight. So that's important, but then also making sure that we're cutting the nails straight across. So this is a proper way to cut the nails. Curving the nail is actually improper because what happens is that however we cut the nail is the way the nail will grow. So if we're concerned about the nail growing into the side of the skin here, we don't want to cut the nail on an angle, because then the nail will grow more into the skin, because it's going to grow every direction that we cut, right? So it's going to grow more towards the skin. So we want to try to practice cutting the nail straight across, which I know for me would take some getting used to, because I'm used to cutting mine on a curve as well. So that would be one way to treat it. Sometimes doctors will just cut out, I mean, it's a lot of the nail. It ends up looking like a third of the nail. They'll just cut out the whole side of the nail and pull it out of the skin. It's really gross. But that's always an option as well if it's a really bad one. Lastly, we have what's called a subungual hematoma. So remember, a hematoma is a juicy bruise, and subungual means below the nail or under the nail. So subungual hematoma is bleeding or bruising under the nail. So this is a very bad one over here. That's covering the entire nail. So the blood under the nail, if we were to not treat that, or even if we do, the blood under the nail that looks like that can last for months. I've had some smaller ones that lasted for a year. This can happen from getting stepped on, improper shoe fit. So again, if that toenail is jamming into the front of the shoe, possibly. I got mine on about a third of my nail from wearing pointy-toed heels that were too tight for me. And or also shearing. So if a shoe is rubbing on that spot, it could also cause a problem. If we have somebody who has brand new bleeding under that toenail, then what we can do as an athletic trainer or a doctor is we can actually drill a hole into the nail. So we'll just make a little hole very carefully and very slowly at some level, like probably approximately in the center where the bleeding is. And basically you melt the nail. So I usually, we have special tools for it as well, but I've most commonly used a paper clip and a candle to heat up the paper clip, and then you melt through the nail very slowly. And then when you get close to the nail bed, as you go through the nail itself, the person will feel a pop, or you'll hear a pop, and then the blood will just all come out, and the person will feel a lot more comfortable. If somebody has a subungual hematoma over more than a third of the nail, they are likely to lose the nail. If we drill a hole in the nail, they are also likely to lose the nail. So that's always a consideration when somebody has a subungual hematoma, that if it's a big one, most likely they're going to lose the nail. And hopefully it will grow back normally, but they oftentimes don't. And that is the end of our foot lecture.